We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for the treatment of STIs and explained the pathophysiology and clinical presentation of some of these STIs. Now let's interpret diagnostic laboratory findings to confirm the presence of genital herpes, gonorrhea, chlamydia, or syphilis in a patient. Let's take a look at diagnosis of genital herpes simplex virus infection. Now, if the genital lesions are present, clinical diagnosis should be confirmed by a type-specific virologic testing from the lesion, and that's typically with a nucleic acid amplification test, and that has a pretty good sensitivity of that approaches almost 100%, so 91 to 100%. Whereas if you were to culture this, sensitivity of viral culture is low. And then there is a type-specific serologic test. So serology is essentially from the blood, whereas that nucleic amplification test was done on the specimen directly from the lesion, which means there is no lesion. You can't really do this test because you need to have a specimen. Whereas serology can be done at any time, whether there is lesion or not. So essentially, you want to see if someone has, latent HSV. And the serology test that's type specific, it can distinguish between HSV1 and HSV2. It essentially detects different glycoproteins from each of these. And it has a good sensitivity, 80 to 98%, but it has a poor specificity. So when there is a positive test, you have to make sure that it's not a false positive. So it needs to be confirmed with a second method. Now, these say type specific because there are some tests out there that are type common antibody tests. They just tell you if somebody has HSV infection. It doesn't distinguish between HSV 1 and 2. So the CDC guidelines from 2021 do recommend to use type specific, so you can distinguish between HSV 1 and 2. And that's implications for treatment because we know that if it's HSV 1, it's less likely to have recurrences, whereas HSV2 is more likely to have recurrences. So that essentially determines our treatment strategy, which we'll cover shortly. Now, when it comes to screening, these are the US PSTF recommendation. So they recommend against routine screening by blood test, so essentially the serology test, for genital herpes infection in asymptomatic people, including pregnant individuals. So it's not recommended. It's only when people have symptoms that then you essentially do the NAT and diagnose them with genital herpes. Now, when people do have genital herpes, those ulcers actually increase the risk of HIV transmission. So for that reason, all persons with genital herpes should be tested for HIV. Now, diagnoses of chlamydia and gonorrhea are pretty similar. So essentially, you use nucleic acid amplification test from the specimen. And the specimen is essentially the site of infection. So for women, if it is a urogenital infection, so vaginal or cervical swabs, or you can use a first void urine test to detect either chlamydia or gonorrhea. And typically these are tested at the same time. So because the manifestations are pretty similar, when you suspect one, you test for both of these. So that makes it more straightforward. For men, urethral infection can be diagnosed again using first void urine or a urethral swab. And I will tell you that most routinely people just get the urine sample for these. If you suspect the route of transmission was rectal or oropharyngeal, those sites can also be swabbed because a urine sample might test negative where somebody may have oropharyngeal infection. So all three sites may be needed to be tested in certain individuals with risk factors. And something that's specific for chlamydia and gonorrhea is that patient collected specimens are equivalent in sensitivity and specificity to those collected by a clinician using that. So it doesn't matter if the patient swabbing, for example, doing a rectal swab on their own, or the physician doing it. So technique is not really as important, or at least the studies have not shown much difference. Now, while we're doing diagnosis of chlamydia and gonorrhea, because of the common risk factors, these people should also be tested for HIV and syphilis. Diagnosis of syphilis is primarily based on serology. We do not have a nucleic acid amplification test available on the market. Therefore, we have to rely on serodiagnostic tests. In general, we can divide these serology tests into two categories. The first one is non-treponemal tests. These essentially measure IgM and IgG in response to lipoidal materials from the organism. And two of the common ones that are used in the US are RPR, so essentially rapid plasma reagent test that essentially measures this in the plasma. The second one is VDRL, so venereal disease research laboratory test. This one is available for plasma and CSF, and most commonly is used for diagnosis of neurosyphilis since it is available in an assay for CSF. The second type of serology is treponemal test, and this essentially measures antibodies directed against T. pallidum, and there are a dozen of different tests that are cleared by the FDA. Perhaps the most common one is the FTA-ABS test, but essentially these are all measuring antibodies directed against the T. pallidum. Now take a look at the kinetics of these serologies. So here on the x-axis, we're looking at time since the patient developed syphilis. So initial phase is early syphilis, followed by latent syphilis and transitioning into late syphilis. You can see that within the first 2 weeks, essentially the treponemal antibodies start to go up, and then once this goes up, they pretty much stay steady throughout life. Whether the patient receives treatment or not, these antibodies will be detectable. So when somebody tests positive, if they have received treatment in the past, they cannot distinguish between new infection or a previous infection that was treated. Now, somewhere between at 4 weeks, essentially non-treponemal antibodies start to go up, and this actually responds to treatment. So as time goes on, if there is no treatment, these levels will slightly go down. However, if the patient does receive treatment, the levels drop significantly. And in general, about 15 to 25% of patients who receive treatment will sero-revert, meaning that these non-treponemal antibodies will become undetectable. And then the remaining patients who get treatment, they are referred to as serofast, meaning that the levels of non-treponemal antibodies significantly drop, but they don't necessarily become undetectable. And because of this, essentially non-treponemal antibodies can be used to measure a response to treatment. So essentially, if there is a two dilution drop or a 4-fold decrease in the levels of non-treponemal antibodies, that means the patient is responding to treatment. Whereas treponemal antibodies remain steady, so they are essentially treated as either a positive or a negative, whereas with non-treponemal antibodies, we can not only get a positive and a negative, we can also get titers so that we can trend the levels of these titers. And there are two different algorithms for diagnosis. The traditional way is that you essentially start with one of the non-troponemal tests. So in the plasma, it would be RPR. And if it's negative, you do not treat. And if it's positive, you do a confirmatory test. So then you use a second test to confirm it. So if you use the non-troponemal test, then you confirm with the troponemal test. And then if it's positive, you confirm that it is a true positive and you treat. But then if it's negative, then you assume that this was a false positive, so you do not need to treat. Okay. Now, this is something that traditionally was used. The problem is these tests are not perfect. So when your RPR is negative, there's a chance that this actually might be a false negative and you may miss some people. So then there was the reverse algorithm where you do the opposite. So instead of starting with non-troponemal test, you start with your troponemal test. And if it's negative, you do not treat. Whereas if it's positive, then you get confirmation with your non-troponemal test and then you treat. So both of these algorithms are out there and they have strengths and limitations. And that's because these tests are not perfect.